Hello and welcome to my channel. In this lecture, we'll conclude our discussion about the kidney. So we discussed the main structure of the kidney and its blood supply and venous drainage. And today we will be discussing the collecting system. Okay, let's begin. The upper urinary tract comprises a series of calyces. You see these calyces that each calyx is opposite the renal papilla to receive the urine secreted by the kidney. These minor calyces join together to form major calyces, and two or three major calyces formed, and then at the end the major calyces form the renal pelvis, or the pelvis of the ureter. This is the renal pelvis or pelvis of ureter. This is how urine is collected. By the way, from this part downwards, it arises from the urinary bladder as a ureteric bud. This is in embryology. While the rest of the kidney, the part we studied in last lecture, is developed from the nephros. So this ureteric bud should ascend and rise and meets the part from the metanephros to collect the urine, future urine secreted by the kidney. And if faulty as you can say, meeting happened between the calyces and the corresponding papillae, this will lead to accumulation of urine inside the kidney in the form of cysts, and this is the typical case of polycystic kidney. Of course, some of the calyces will be connected and the kidney may function normally, maybe until 40 years or so, but eventually it will collapse because of the back pressure and hyperhidronephrosis developing over the years. So the minor calyces coalesce together and form the major calyces, and then form the renal pelvis, and then at the pelviureteric junction the ureter starts. Okay, now the ureters are 25 or 30 centimeters long. Of course, a muscular tube descends medially on the psoas major, as you can see here, and on the psoas major it's between the genitofemoral nerve deep and the gonadal vessel superficial. You can see this is clearly here. This is the genitofemoral nerve, and this is the gonadal vessel. In this case it's the testicular artery. Between them passes the ureter, and enters the pelvis by crossing the common iliac arteries. See how it crosses the common iliac arteries. Behind it is the common iliac and the sacroiliac joint. Now it's becoming in the true pelvis, and descends till the level till the level of the ischial spine, where it curves anteromedially to open in the posterolateral angle of the urinary bladder. Okay, level with the ischial spines, the curve results. So this is the course of the ureters, either the right ureter or the left ureter. Now, worthy of mentioning here, when it crosses the common iliac, it becomes anterior to the internal iliac, and in females on the side of the pelvic wall, there's an ovarian fossa anterior to the internal iliac and ureter. So ureter might be involved in mass occupying lesions at the ovary, for example, as ovarian carcinomas. Remember this. The right ureter, as you can see here, it's overlapped by the second part of the duodenum at the beginning, the pelvis. Of course, because the second part of duodenum covers the hilum of the right kidney, it descends on the right side of the inferior vena cava, and on its way downwards, it's crossed. Remember the blood supply of the colon, we have the right colic and we have the ileocolic branches. It crosses these branches cross the ureter as it descends on the right side. So remember, it's deep to these branches. Divide the abdomen in layers. The ureter being the deepest layer on the psoas major muscle. And as it descends, it's crossed also by the root of the mesentery. Remember, the root of the mesentery started crossing the third part of duodenum, then the aorta, then inferior vena cava, and the psoas major with structures on it. And the ureter is on the psoas major, and also is crossed by the terminal ileum as it opens into the cecum. Now, the left ureter is crossed by the upper left colic vessels and lower left colic, or you can call it left colic branches and sigmoid branches. And remember the surgical landmark, that is the apex of the intersigmoid fossa, and between the limbs of the root of the sigmoid mesocolon. When you introduce your finger below the sigmoid mesocolon and go up at the apex and push back, you are on the left ureter. This is a surgical landmark. Of course, because you can't see it in surgical field because it's covered by peritoneum. It's a retroperitoneal structure. Constrictions along the course of the ureter. There is one at the pelviureteric junction, one as it crosses the common iliac artery opposite the sacroiliac joint at this level approximately, and one as it kinks forwards level with ischial spines. A kink will make a constriction in the wall, in the lumen of the ureter, and as it opens into the urinary bladder, because it doesn't open directly in the urinary bladder, it pierces the wall of the urinary bladder and has an intramural part, which is it runs partly in the muscle wall of the urinary bladder and then opens inside the urinary bladder. Okay, so remember this. This is a site of, these are the sites of constrictions. The pelviureteric junction, as it crosses the common iliac artery, at the kink where it curves anteromedially at the level of ischial spine, and as it enters the urinary bladder. Now, when examined the pelvis of the ureter, they found a node, a pacemaker-like nervous tissue in the wall of the pelvis of the ureter that gets excited when the pelvis of the ureter gets distended, means it's full of urine. So this regulates the peristaltic waves along the ureter to push urine down to fill the urinary bladder. Of course, since the ureter is a long organ, as we said, it's 25 or 30 centimeters long. Its blood supply varies. It takes from whatever artery besides it, from the renal, from the aorta, from the gonadal vessels, from common iliac, from internal iliac, vesical, and even uterine arteries lower down. So it takes multiple sources of blood supply to cover this long structure, which is the ureter. Okay. Now the lymphatics as well drains into different parts of the lymphatic system. Upwards drains into the para-aortic lymph nodes as you go down to the common iliac and internal external iliac lymph nodes. So along the way down, it drains in the corresponding lymph node related to that area. Remember this. And innervation by also from different sources, by renal, aortic, superior and inferior hypogastric plexuses. The superior hypogastric plexus, we mentioned before, it's at the bifurcation of the aorta Inferior hypogastric plexuses are on the lateral pelvic wall, and we will study these plexuses with the pelvic vessels and nerves, so don't worry about it. But just waiting to reach that region. So it takes from all these, and expect that the pain from the ureter, which is a ureteric colic, because of a stone, for example, is propagated along the from the lower 3 thoracic and upper 2 lumbar spinal cord segments. Means the pain will be propagated to the loins and groins, right? From the stone, the pain to the loins and groins along these spinal cord segments, as well as with the genitofemoral nerve. It propagates to the scrotum in males and labia majora in females, and this is typical description of the pain accompanying the either renal or ureteric stones, especially ureteric stones when they move and especially if they were of the oxalate types that have spikes on its surface. So actually it injures the ureter as it descends down and blood occurs in urine. This is about the renal colic and the innervation of the ureters. Now, this concludes actually the collecting system of the urine so far, and we will study the rest of it, the pelvic ureters and urinary bladders in the pelvis. So don't worry about it. But for now, we're left up with the suprarenal glands. On top of each kidney is a suprarenal or adrenal gland. Now, the right adrenal gland, as you can see here, is rather pyramidal in shape, and it's high up. It does not reach the hilum of its kidney. But the left side is rather semilunar in shape. Here it's pyramidal, but see, goes down and reaches the hilum of its kidney, the left kidney. So they describe the left suprarenal gland as being semilunar in shape, and the right is pyramidal in shape, and the right is behind the inferior vena cava. Of course, this is very hard and difficult to excise. For example, in cases if you have a choice, if you have a tumor, if the patient has a tumor in the right suprarenal gland, like a pheochromocytoma, for example, there is a high risk to injure the thin-walled inferior vena cava. It's a disaster, of course, if you cut the inferior vena cava in the surgical field. You will not be able to see anything because the field will be full of blood. Now, if there is a case in which there is bilateral hypertrophy of the suprarenal glands, suprarenal cortices, for example, due to a non-local cause, like, for example, increase the ACTH secretion. So you have the choice to remove one of the glands. If you have the choice, prefer, of course, to remove the left side rather than the right side, to get away from the inferior vena cava as much as possible. Okay. Of course, both glands are anterior to the crury of the diaphragm, the right in front of the right crus, the left in front of the left crus, separating it from the aorta. The left adrenal gland, as I told you, it may reach the hilum because it's longer, and in front of the left crus of the diaphragm. It's behind the cardia of the stomach. And lower end, because it's long, as we described. So the lower end might be behind or posterior to the splenic artery and the pancreas, because the pancreas crosses the kidney and covers the hilum of the left kidney. You remember this from the relations of the kidneys. So these are the relations of the suprarenal glands. The microscopic structure of each gland demonstrates a cortex. You see, all this is a cortex, and the medulla. The medulla of the gland is actually a sympathetic ganglia, rich of chromaffin cells that secrete adrenaline more than noradrenaline. You will be asked about this. The main neurotransmitter in the adrenal medulla is the adrenaline, not noradrenaline, and it's secreted or poured in blood in fight or flight situations, in emergencies, I mean. Rather than the noradrenaline, which is distributed all over the body with the sympathetic nerve terminals. The cortex of the medulla, there is a question that you will find always in exams, which is it essential to life? Yes, the cortex is essential to life. The medulla is non-essential to life. You can remove it. The cortex differentiates into three zones or three layers. The zona glomerulosa, superficial part, zona fasciculata at the middle, and zona reticularis at the deepest part of the cortex. Now, the zona glomerulosa cells, they form or secrete the mineralocorticoids like aldosterone for the electrolyte balance of the body. The zona fasciculata cells are responsible for secretion of the glucocorticoids like the cortisol, and the zona reticularis for sex hormones like the androgen, estrogen, and progesterone. So you can imagine the amount of changes in the body if something wrong with the cortex of the adrenal gland, which will affect metabolism, even the outer, figure, the skin, and all the organs actually will be affected in the body if something wrong with the renal or the adrenal cortex. The cortex is controlled by the AC adrenocorticotropic hormone secreted from the pituitary gland. And as I told you, it's essential to life. And the medulla, as I said before, it is actually a sympathetic ganglia. And remember, it receives through the renal plexus the least and lesser splanchnic nerves. These are the stimulants, actually, or the synapse here in the medulla of the adrenal gland. Now, the blood supply of the suprarenal or adrenal glands, the arterial supply comes from three sources. A higher source from the inferior phrenic artery, the first branch of the aorta as it enters the abdomen to supply the inferior surface of the diaphragm. The middle suprarenal artery that comes directly from the aorta, and inferior suprarenal artery that comes from the renal gland, from the renal artery. So inferior suprarenal from the renal, middle suprarenal from the aorta, superior suprarenal from the superior phrenic. Both sides are the same in arterial supply. So actually it's rich in blood supply. While the venous drainage differs in both sides. It's only one vein that drains the gland. It's called the suprarenal vein. But on the right side, the inferior vena cava is already in intimate, actually close relation with the adrenal gland. So it opens into the inferior vena cava directly. But the left suprarenal vein is away from the inferior vena cava, so it will take a hitchhike, which is the left renal vein. So the left suprarenal vein drains into the left renal vein that will take it to, of course, the inferior vena cava. The lymphatics along the vessels to the sides of the aorta, so to the para-aortic lymph nodes, and the innervation by preganglionic sympathetic fibers, as I told you before, that synapse on the medulla of the gland, the chromaffin cells component of the medulla. So this is the blood supply and venous drainage and lymphatics of the suprarenal glands. It's easy. This lecture is easy, actually. I brought you a plate to show you the various effects of cortical atrophy, like in Addisons disease, like general weakness, anemia, electrolyte imbalance, and pigmentation, and hypotension, hyponatremias, hyperkalemia. See, all different parts of the body systems are affected by the deficiency of the atrophy of the adrenal cortex, and in this case it's called the Addisons disease. You will study this in details in physiology. And the other way around, if there is hypertrophy of the cortex of the adrenal gland, there is a physiologic hypertrophy that occurs normally in pregnancy, and there is a pathologic hypertrophy, like in tumors, for example, like Cushing's disease or Cushing's syndrome, in which there is obesity, a hair redistribution in females and males, and diabetes, because there is an anti-insulin effect of the hypertrophy. In males, there will be impotence, hypogonadism. Hypogonadism means small size of the external genitalia, and amenorrhea in females. They don't get the regular menstrual cycle. In females, there's the opposite. There's virilism and hirsutism. In males, there's feminization. You detect that by looking at the pubic hair, for example. The pubic hair obtains an upper horizontal border instead of an upper border extending to the umbilicus in males. The pubic hair extends to the umbilicus in males, but in females it has an upper horizontal border, and this is what happens to males affected with a cortical hypertrophy. In addition to feminization and gynecomastia. Gynecomastia means enlargement of the breasts in males. In the fetus, if this occurred in the fetus during development of the sex of the fetus, so the result is a pseudo-hermaphrodite due to increased androgens. You cannot determine by the external genitalia if it's a male or a female. Only the internal organs will decide if this is a male or a female, and surgical intervention comes later. Now, in children, there will be early puberty in males and early menstruation in females that may start at 5 or 6 years, by the way, if there is something wrong with the adrenal cortex in the hypertrophy side, not the atrophy side. So this concludes the urinary organs in the abdomen, the kidneys and ureters, with the suprarenal glands, because they are related to the kidneys. And I hope you got the maximum benefit from this lecture, and thank you very much for watching.